got everybody? All right. Good morning.
Good morning.
How was that chapter? It was pretty good?
Yeah.
All right, so today we're going to go over chapter 26, bleeding. Does everybody have it up on y'all's laptops? All along?
Yes, sir.
So, what's the biggest thing with bleeding we need to worry about?
Bleeding out.
Stopping it before that even. Recognizing that it's happening. So, finding out that there is a bleed going on, recognizing that bleeding, and then understanding how to stop it. And yes, stopping it. I do like that answer. So, bleeding could be internal or external. Bleeding can cause weakness, shock, and death. So, with internal bleeding, what's one thing we really got to keep in mind and think about?
You can't see it.
We can't see it. And what's another thing we need to think about as well? Not just that we can't see it.
We can't do anything about it.
We can't do nothing about it, and also we don't know how much blood they're actually losing, right? Let's see. All right, the cardiovascular system circulates blood to cells and tissues, delivers oxygen, nutrients, carries away waste products, responsible for supplying and maintaining adequate blood flow. All right, so three parts. You've got the heart, which is your pump, your blood vessels, which is your container, and fluid, so the blood and the body fluids. And as you'll see in your diagram right here. So the heart needs a rich and well blood supply. Works as two paired pumps. You have your upper chamber, the atrium, and lower chamber, ventricle. Blood leaves each chamber through one-way valve. So does everybody kind of understand what that is saying by a one-way valve? So basically it's like a clapper valve. For all the firemen in here, think of it like a water pump. Basically as that opens, that closes, blood's not going back that same way in a sense. Does y'all's PowerPoint look like this with the diagrams in it, by the way? That I just had up? More diagrams. All right, so this is kind of what we're describing with that. Once that blood goes out, it's not going to flow back in that same way. It has that one-way valve that's going to prevent that from going through. So the right side of the heart circulates blood from the body to the lungs. The left side of the heart circulates oxygen-rich blood from the lungs to the rest of the body. This is the most muscular of the two pumps because it must pump blood to the aorta and arteries in order to reach all cells of the body. So, what side is the heart? If we're looking at the patient, on the patient side, if it says right side, it's going to be your left. There you go. Blood vessels and blood. So your arteries carry blood away from the heart. Capillaries pass along the cells and link arteries and ventricles. Smaller vessels that contain arteries and capillaries are what? It says it. There you go. All right, so veins carry blood from the tissues to the heart. Ventricles, very small, thin-walled vessels that empty into the veins. So, out of our, I guess what we would for describing this, blood lines, what would be high flow, what would be low flow blood? What would be something we'd have to worry about, basically having an ooze versus having a squirting blood?
Arteries are high flow.
Say it
And then veins are low flow.
Say it louder, you're good.
Arteries are high flow and then veins will be low flow.
There you go, yep. So just kind of keep that in mind too. This is still on blood vessels and blood. Oxygen nutrients pass from the capillaries to the cells. Waste and carbon dioxide diffuse into the capillaries. So it's really important as y'all are reading y'all's textbook or online, it's those little boxes in the corner that have little notes and stuff. Take a few minutes and read over those too. In some cases, you're gonna have more information in those than the actual text of the book. All right, so your blood contains red blood cells responsible for transportation of oxygen to the cells, carbon dioxide away from the cells to the lungs. So how many people have already read this chapter? Raise your hand. All right, so what else does the blood contain before we move to the next slide besides red blood cells? So, platelets and plasma, yeah. So, white blood cells are responsible for fighting infection. Platelets are responsible for forming blood clots. Then we have plasma. So, going back to this though for a second, as we're thinking about platelets, which is responsible for forming blood clots, so you got to cut. That's what kind of stops that bleeding. So someone who does not have a good number of platelets, what's something that could happen possibly?
Free bleeding.
They don't clot, and that's something we got to kind of keep in mind as well. Going back to our bleeding control. And this kind of goes right along with that. Blood clot formation depends on change in the blood vessel walls, blood's ability to clot. So right there, our blood's ability to clot. So kind of going back to your last few chapters, you got someone with a cut on their arm. What's the very first step to do for that? Put pressure on it. I can tell somebody's been reading. Good job. So we do that. That doesn't work. What's the next step? Say it again. So elevate that possibly if you can. And if that still don't work, what's the last resort? We're skipping a few, but what's the last resort? There you go. I skipped one. So when tissues are injured, platelets begin to collect at the site of the injury. Red blood cells become sticky and clump together. So going into your nervous system, that monitors the body's needs, allows blood flow, automatically redirects blood away from other organs to the heart, brain, lungs, kidney. In an emergency, adapts to maintain homeostasis and perfusion. So what does that mean? What do you think that means more or less as far as a trauma call? Or it doesn't even have to be, more would be a trauma, but not necessarily. Could be something else, but what do you think that means for a patient that has some type of bleed as far as blood in the body? Where's that blood going to actually try to go to versus not go to on their body? Kind of go into the trunk area where all that stuff I just said is listed versus going to your extremities. So if you see an extremity possibly turn a little bit blue, that may not mean they're oxygen deficient. It could just be that same situation where blood's not getting circulated good, that's staying in that core area, the trunk area. All right, so perfusion in the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. So thinking about this a little bit more in depth, can there be a organ or kidney that is not getting enough blood supply to it, but the rest of the body is possibly, and that affect that organ or kidney or anything else? What's one example of that with your heart? Would heart failure possibly fall into that a little bit as well? It could. Speed of blood flow, fast enough to maintain circulation, slow enough to allow cells to exchange oxygen and nutrient for carbon dioxide and waste. Some tissues need constant supply of blood while others can survive with very little. So this goes back to what we're talking about a few slides ago with the need for your trunk and all those organs that we mentioned to have a constant supply of blood versus your limbs could possibly do with very little blood or blood flow. Now that does not mean if your leg gets slashed open and you lose blood completely that your limb's going to survive necessarily. That might not be. But as far as a circulation, it might still be able to survive with limited. So all organs and organ systems depend on adequate perfusion to function properly. Death of an organ system can quickly lead to death of the patient. Emergency care supports adequate perfusion until the patient arrives at the hospital. the heart requires constant supply of blood. So if the heart doesn't have blood, what does that lead to?
Yeah.
Correct. All right, external bleeding. Hemorrhage means bleeding. External bleeding is visible. So this is kind of what we talked about in the beginning. Basically, someone, let's say, cut their arm open, leg open, you see that bleeding, that would be external bleeding. So for those who've read already, before we move on, I think she's going to cover in a little bit another chapter more of trauma related. But what's one other thing besides what we mentioned a few minutes ago as far as bleeding control that we could do for extremities? Say it again, you're good. Yep, packing. Does everybody know what that is? All right, I think we're going to actually do some of that later too. All right, so more on external bleeding. With serious external bleeding, it may be difficult to tell the amount of blood loss. Blood looks different on different surfaces. Estimate the amount of external blood loss. Body will not tolerate blood loss greater than 20% of blood volume. So remember, that's going to be different on a child versus an adult based on their size and how much blood volume they have. So really important with this slide, blood looks different on different surfaces. If you're on pavement versus carpet, that carpet's going to soak up some of that blood and you're not going to be able to tell, just like if it's a dark surface or a light surface. If you're on a hardwood floor, you're going to be able to see a lot more because it's going to pool a lot better. Versus blacktop or cement or concrete, that's going to kind of offset how much that is. One thing, if you do any bleeding control, what's one good idea possibly to do if there's a lot of blood, not just a little cut, but a lot of blood? What's one good thing to do with those bandages? No, not that far.
No,
As far as going to the hospital. Bring them, if it's a large enough blood loss where you're not sure how much they lost, if you have time, throw them in a bio bag and take them with you. They can actually weigh those out at the hospital and have a formula to tell pretty close to how much blood they lost. Especially if you're unable to tell, especially at night, that's where it really gets a little tricky. All right, changes in vital signs may occur with significant blood loss, increased heart rate, increased respiratory rate, but decrease in blood pressure. So always keep an eye on that blood pressure. So with a patient that has a decrease in blood pressure, what's something we have to watch them to go into? All right, and what do we do if you suspect they are going into shock? Say it. One thing, what's another thing we might want to do for them?
Oxygen.
Keep them cool, keep them warm.
Depending on the situation, environment, possibly keep them warm. Most likely they're going to get cold already, so keep them warm. And what's the big major thing though with that? Rapid transport to a facility. So how well people compensate for blood loss is related to how rapidly they bleed. Adult can comfortably donate 1 unit of blood over 15 to 20 minutes. If similar blood loss occurs in a much shorter time, the person may rapidly develop symptoms of hypervolemic shock. Consider age and pre-existing health. So that's the biggest one there. I know we just talked about a child versus adult losing the same amount of blood. It's going to be different for the outcome, but also if you have 2 adults of the same age, but one might have a health condition, that also is going to play into. So don't just think you have an adult that's 30 years old, they're good to go. There's other factors to keep in mind. Characteristics of external bleeding. Serious condition with bleeding, significant MOI, which is, what is MOI? There you go. Patient has poor general appearance and is calm. Signs and symptoms of shock, like we just discussed. Significant blood loss, rapid blood loss, uncontrollable bleeding. So as we mentioned with our bleeding control, that last step for uncontrollable bleeding would be
Tourniquet.
a tourniquet, depending where it's at on the body. Obviously we can't put a tourniquet on the trunk or on the neck, but other spots we can, just to keep that in mind. All right, arterial bleeding. Pressure causes blood to spurt and makes bleeding difficult to control. That's what we were discussing a little while ago. This though is going to be brighter red and spurts every time you have, basically along with the pulse. Ventrous bleeding, this is going to be dark red, flows slowly, rapidly bleeding on the size of the vein, does not spurt, and is easier to manage. Sometimes it's actually not easier to manage, depending on, once again, the person's age and condition. All right, capillary bleeding. Bleeding from a damaged capillary vessels, dark red oozes steady but slowly. So this could be a cut wrist, this could be, as pictured here, a cut leg, or like a fingertip or anything like that. All right, so clotting. Bleeding tends to stop rather quickly within about 10 minutes. When skin is broken, blood flows rapidly. The cut end of the vessel begins to narrow, reducing the amount of bleeding. Then a clot forms. Bleeding will not stop if the clot does not form. So with this type of bleeding, if y'all get there, still apply pressure. That will actually help that clot form a little bit and control the blood flowing. And this kind of goes back to what we talked about a little while ago, depending if they actually are unable to clot their own blood. That's something you got to keep in mind as well. All right, so with this, patient lacks blood clotting factors. Bleeding may occur spontaneously. All injuries, no matter how trivial are potentially serious. Patient should be transported immediately. What age group will we see this more in? Geriatrics. Possibly you might see a geriatric just bump up against a cabinet or something and they'll tear their skin and bleed uncontrollably. That's an example of this. All right, internal bleeding can be very serious because it's not easy to detect immediately. Injury or damage to internal organs commonly result in internal bleeding and cause hypothermic shock. So this is where we said we may not even know that they're bleeding in there. So most of your high trauma calls, you just have to consider they might be bleeding inside right off the bat and keep that in the back of your head. What's some signs though that will show, possibly show, that they're bleeding internally on the patient's body? Go ahead, say it louder. Yeah, you're good. So bruising around maybe a chest or stomach area, like a bluish, brownish color, discoloration, drop in blood pressure for unknown reasons as well. Or if they start vomiting, throwing up blood, or defecating or urinating blood as well is another sign. So causes for internal bleeding: stomach ulcers, lacerated liver, ruptured spleen, or broken bones. So what medication, we're jumping back a little bit, but when we're considering ulcers, do we not want to give a patient? Very good. So mechanism of injury for internal bleeding. High energy mechanism of injury should increase your index for suspicion of serious unseen injuries. So that's kind of what I just mentioned. If you have a wreck that even if they walk out of it, you just kind of got to keep in the back of your mind, there's a good chance that they did have or do have some type of internal bleeding. Internal bleeding is possible whenever the MOI suggests that severe force affects the body, blunt trauma or penetrating trauma. So you have a gunshot wound or a knife wound to a patient, you see the one spot where that entry and possible exit made. Could there still be other trauma as well into that body?
Mm-hmm.
Why could that be for, let's say, a gunshot wound? Yep, so even if you have an entry and an exit wound, you don't know what that, what type of bullet that is, as far as like some have metal jackets or spears on them, but also you don't know if that bullet's gonna bounce around in there. You might see, oh, it went straight through, but that bullet might come straight at an angle here and bounce out in the middle of your back because it bounced around off bones or what. So you gotta keep that in mind as well. Don't just think, oh, it has a clear entry and exit wound, or it's a knife wound that went straight in. You never know what that could do for penetrating. So signs of injury, don't forget your DCAP, BTLS, so deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Everybody understand all those, or do I need to go through them? Good, all right. So internal bleeding is not always caused by trauma. Non-trauma causes include bleeding ulcers, bleeding from the colon, ectopic pregnancy, so for ulcers and bleeding from the colon, what's one way we just said as far as signs that we could tell possibly, and we're not necessarily going to check, but they might be able to tell us. Say it again. Vomiting blood, or what's another two ways? Stools or urine, that they're passing blood. Obviously, you're not going to go and check right off the bat, but if they tell you that, or you might need to ask that, and you can determine that. So they're going to have pain for, this is going back to internal bleeding still, they are going to have pain, swelling as well, distension, you're going to see them swell up a little bit possibly, and it ain't just stomach, it could be in their legs, neck, wherever. Tachycardia and bruising would be the main key ones to kind of keep in mind for watching that. So bleeding from any any body opening, pain, tenderness, bruising, and swelling, broken ribs, bruising over lower parts of the chest, or rigid distended abdomen. Again, so with this one, the biggest thing to kind of keep in mind is broken ribs. What can broken ribs do? Puncture, yeah. So still on signs and symptoms, hyperfusion, change in mental status, weakness, fatigue, dizziness, change in skin color, later signs, tachycardia, weakness, fainting, dizziness, rest, thirst, nausea, vomiting, cold, moist, clammy. So this kind of goes into more signs of shock. They're going to start getting cold, even if it's 90 degrees out, so you're going to still want to keep them warm, put a blanket on them or whatnot. If they're thirsty or hungry or really want them to eat anything, no, we're going to try to hold off on that. So the biggest things, if you see this, go ahead and start treating for signs of shock. So continued shallow rapid breathing, dull eyes, dilated pupils, capillary refill of more than 2 seconds in infants and children, weak rapid pulse, decreasing blood pressure, altered level of consciousness. So if someone's out in and out, able to talk to you though, still answer your questions, could that still be altered level of consciousness? Very possible. They don't have to be talking crazy or barely mumbling. Even just kind of talking 2 sentences here and there can also still be that. We kind of talked about that. All right, so follow your standard precautions, wear gloves, eye protection, possibly a mask or gown. The biggest one with this, obviously we're always going to wear gloves on every call, but a lot of these other things you really don't see, but eye protection. You get on a call splurting blood all over, try to grab some type of eye protection if you can, at least. So make sure the patient has an open airway, is breathing adequately, provide high flow of oxygen, control obvious life-threatening bleeding as quickly as possible. All right, so several methods are available to control external bleeding. So this is kind of what we already discussed a little bit, but so direct pressure, elevate, pressure dressings or splints, tourniquets, insert dressing, or wound packing. And then, of course, I know don't say it, well, it might be, no, this is it. Of course, at the very end, depending where it is, a tourniquet. So most common, so when we look at direct pressure, most common and effective way to control bleeding, pressure stops the flow of blood and permits normal coagulation to occur, basically our blood clots like we're talking about, allows pressure with your gloved fingertip, hand over the top of a sterile dressing, hold uninterrupted pressure for at least 5 minutes. So you've got that on whatever you're using on the patient's bleeding out. Are we going to want to rip that off if that blood gets soaking through there? We're just going to want to put another one on top of it. There you go. So firmly wrap a sterile, self-adhesive rolled bandage around the entire wound. Stretch the bandage tight enough to control bleeding. Do not remove dressing until the physician has evaluated the patient. A tourniquet is useful if bleeding cannot manage direct pressure. So a couple things with this: if you have a traumatic call, whether it be a bone sticking out, amputation, or it could just be a bad enough cut, take a picture. Before you wrap it, take a picture of it. Now, two things I'm going to say with that: do not post any pictures on social media or show anybody else that's not on that call, and delete the picture after you're done with that call. But if you wrap it, the hospital, for firemen, y'all get there first, the ambulance might want to see it, or for ambulance, when y'all get to the hospital, they might want to see it before ripping the bandages off. It might help them see it. So the other thing when we're doing bandages, don't just lightly go around. Wrap that tight where you actually see almost the skin pinching itself almost. The whole point of that is to control the bleeding, not just to look, it might make their arm numb or tingly, but that's part of doing that, to control bleeding. Hematologic agents, gauze can pack into larger wounds with direct pressure. Application of a tourniquet if not possible. Without dressing is pregnant with a chemical compound that slows or stops bleeding by performing clot formation. I don't know too many places that have these, but it's something y'all do need to know. So wound packing, I know it mentions it's here. Can't remember if it mentions this later or not. Does everybody know the process of doing that?
No, can you tell me?
So basically, let's say you have a cut on that wound. You're going to take sterile gauze, gloved hands, put that gauze in there. A good idea is to keep one finger just at the edge, maybe screw your tip of your finger on that gauze and use your other to pack it in there as well.
Like in there.
In there, yes. We'll go over it more later with some of these. Now, I'm not saying stick your whole hand in there,
Okay.
but basically just put your finger on that gauze as you're doing, so you're not pulling it in and out, and then go ahead and move it and keep packing, and then put your finger back there. Like I said, we're only talking like your fingernail tip, holding it on there. We'll go over that more here, I think, this afternoon when we're doing some skills stuff. But after you do that, basically it forms where you can't pack any more in there. Just roll the rest up, put it on top, and then roll a separate gauze or something around the outside and tape it off. All right, tourniquets. Useful if a patient has bleeding from an extremity. Several types of commercial tourniquets are available. So big thing with this, tourniquets do not all, they pretty much act the same, but the equipment on them is a little bit different. The biggest idea of it, to explain it, we'll go over this too later. I think we have some over there. But it's a belt in a sense with a piece of metal to, once you put that belt on over an extremity, ties that down, puts pressure on it, and locks in place. So where can we put a tourniquet around the neck?
Okay.
No. And backing up for a second, going back to packing, where can we not pack on a person?
No.
Where else?
Chest.
Nope, say it again, you're good.
Chest.
Yep, the chest. So basically packing would be good for extremities, possibly lower stomach area would be a good spot for that. Tourniquets allow for compression of life-threatening bleeding in areas where standard tourniquet application is not possible. Maybe indicated for severe hemorrhage at the junction of the torso with the arms and legs. So these are different types of tourniquets they have, not just these standard ones. They basically have big blow-up style. Actually, here you go. Kind of a tourniquet, almost looks like this with pressure on it. So these are air splints. They're soft splints or pressurized splints. They may not look like this. Some look like a big balloon. Kind of looks like this, but some actually are different colors. And swallow the entire hand, arm, leg, whatever, and actually measure out to that patient's extremity or wherever that is. Soft splints or pressure splints can control internal or external bleeding associated with severe injuries. Immobilized fractures act like pressure dressing. Use only approved clean disposable valve stems. So I really don't know too many places that actually have these types of splints Most of your places are gonna have your hard splints, which I don't know if we have any of those. Do we have any back there we're gonna go over later? Splints? No. So pelvic binder. This is actually what I was trying to do with y'all about a week ago that y'all didn't really know about securing the pelvis. So it's a type of splint that may indicate for a suspected closed, unstable pelvic fracture, helps to control internal bleeding. So actually, hold on, I see it might be on here. No, it's not. For a fracture of the femur, what's one thing we can't do as far as putting pressure on that if it's closed or open? So for a femur fracture, what's one case that we cannot do as far as putting pressure on that? If it's open, yep. So bleeding from the nose, ears, and mouth. You could have a skull fracture, facial injuries, sinus infections, high blood pressure, disorders with altitude, digital trauma, or cancers. So if they have an uncontrolled bleeding from that, are we going to want to try to stop that? So they got into a car wreck for a trauma call or fell from a tree, whatever, and they're having nosebleed. Are we going to want to try to stop that or allow that to flow?
If there's more pressing issues, then probably not.
Depends on where they leave, how much
So yeah, it would depend on the situation that happened, how much they're bleeding, like you said, where they're bleeding, yes. But we're talking nose right now.
probably not.
So normally allow that to flow, depending, like we said, type of situation occurred and how much blood. But normally allow that to flow so that doesn't build up in the head, skull. So nosebleeds is a common emergency. Occasionally it causes enough blood loss to send a patient into shock. Can usually be controlled by pinching the nostrils together. So bleeding from the nose, ears following a head injury may indicate a skull fracture, may be difficult to control. Do not attempt to stop the blood flow. So this is what I was talking about here. Loosely cover the bleeding site with sterile gauze pad. Lightly apply light compact dressing or compression with a dressing. So with this here for your skull fractures, what's another sign that we could look for on the patient?
Pupils.
Take it a little further, not just pupils, but what else around the eyes? Yep, raccoon eyes or bruising behind the ears as well could also indicate a skull fracture. So a target or halo-shaped stain may occur on the dressing if blood or drainage contains sperm fluid. So where would we see this possibly at? From the body, from the patient.
Ears.
Yep, their ears. So emergency medical care for internal bleeding usually requires surgery or other hospital procedures. Keep the patient calm, reassured, and as still and quiet as possible. Provide high flow oxygen, maintain the body temperature, splint the injured extremity, possibly an air splint if you had it. So just remember with this, maintain their body temperature. Even if it's 90 degrees outside, with them being in shock, you might have to throw a blanket on them as well. The biggest thing going back with this though, for your trauma and bleeding, would be rapid transport. And if you're on a BLS unit, possibly calling for an ALS unit. All right, any questions on that?